Good day, everyone. My name is Milan Simoneau, and I am the Women's Wellness Coordinator here at the PSP headquarters.
And good day, everybody. My name is Anna Smith. I'm the Women's Wellness Program Manager. We are delighted to have this important discussion today on menopause, and this is part two of a three-part series. So thank you for your interest in joining us. Today, we hope you'll gain some evidence-based insights and some practical strategies to support your health, performance, and well-being during midlife for CAF members and for those who support them.
On behalf of our team, I'm pleased to welcome you to today's Ask a Doctor webinar featuring Dr. Hansen, entitled Thriving Through Menopause, Yes, You Can. Please note that this session is being recorded and will be available for viewing on our website after the event. For your privacy, your cameras and microphones are disabled throughout the webinar. If you have questions or comments, you may submit them at any time using the MS Team Q&A feature. While we will do our best to address as many questions as possible, we may not be able to respond to all of them today. Unanswered questions might be covered in a future session. If you wish to listen to this session in another language, you may use the Wordly link provided in the discussion panel to access live translation option or the QR code that is on screen right now. Today's presentation is intended for educational purposes only and does not replace advice from a qualified healthcare professional. If you have personal or specific health concern, we encourage you to speak with your healthcare provider. So without further ado, it is my pleasure to introduce our presenter, Dr. Catherine Hansen, Canadian-trained and U.S. board-certified obstetrician-gynecologist, menopause practitioner, and health advocate. Dr. Hansen, thank you for being virtually with us today, and over to you for your presentation.
My pleasure. Thank you so much. It is so great to be here and to be having this important conversation about menopause. And I will be giving this presentation co-created with Dr. Jennifer McCall as well, who will be presenting in the French version. So Dr. McCall and I have a couple of disclosures here on this slide and nothing relevant to the current conversation. We want to take a moment to respect that this land is the traditional and ancestral territory of countless Indigenous nations. We acknowledge that we are the guests on this land, and we pay tribute and respect the elders past and present. Menopause in Indigenous women in Canada remains understudied, and colonization impacts the way menopause is experienced among Indigenous peoples. Taking a moment to reflect. And Mylène presented our medical disclosure already. And also want to share an inclusivity statement. Each person's experience of menopause is unique. So people who are transgender, non-binary, or intersex may experience menopause. More research is needed to understand the impact of menopause on women and diverse communities. So today we're going to talk about the definition of menopause. We did a previous presentation on perimenopause, so we're going to focus on menopause today, identify main symptoms, review preventative and management strategies, provide an opportunity to ask questions, and I have some pre-submitted questions I will also cover, and to leave with a sense of agency and empowerment to negotiate your unique menopausal transition. So what is the definition of menopause? To define menopause, I take you to the Menopause Society, the straw plus 10. So this is what clinicians use to identify the perimenopause and the menopause period. Menopause is defined as 1 year after the final menstrual period. So what you see there with the bright red arrow is the final menstrual period. And then 1 year later, on the anniversary of that final period, you're considered postmenopause. And so early and late perimenopause, we talked about in the last presentation, that's when periods start to change, cycle regularity starts to change, periods can get further apart, closer together, heavier, lighter. And then you have that final menstrual period, which you don't know is final until a year later. And then you're considered postmenopause, which can be early postmenopause, later postmenopause. And that is essentially defined by the number of years after that final menstrual period. And if you just want to sort of explore the straw criteria, symptoms will change. And we'll go through the symptoms that are associated with perimenopause and early and late, and then postmenopause, early and late. Throughout this transition, there's a declining of estrogen. So this graph isn't exactly accurate. Estrogen starts to decline sort of in the 3 to 5 to 7 to 10 years before that final menstrual period. And there's a lot of fluctuation in estrogen and progesterone related to FSH, which is the hormone from the brain that is regulating estrogen secretion from the ovaries. And so ultimately, as estrogen starts to decline, it's kind of the control center over the symptoms and when those symptoms take effect. So in menopause and postmenopause, initially there's some hot flashes, night sweats, insomnia, irritability, mood changes. A little bit later in the menopause, after the estrogen's been gone a while, there's some urogenital, vaginal, vulvar symptoms, pain with intercourse or bladder dysfunction, and then later some osteoporosis. But that osteoporosis or that bone loss, we're going to talk about, it starts early, and we want to be reaching our peak bone mass when we're in our 20s and 30s so that we're protected from those losses. And everyone's menopause is unique. You may or may not experience these symptoms. You may sail through without trouble, or they may be incapacitating. Menopause is an event every woman will experience, confirmed 12 months after that last menstrual period, and the perimenopause or the symptomatic time frame can last for 10 years. So if you imagine the average age of menopause in North America is 51, you're going to potentially start having some symptoms in late 30s, early 40s. And so some of the pre-submitted questions are related to, I'm starting to have symptoms, but I'm not at this age yet. Could this be perimenopause? Absolutely, it could be perimenopause. And we'll talk about some of the treatment options related to perimenopause and how they may differ or be the same as some of the menopausal treatments that we're talking about here. So we call menopause a natural menopause that occurs naturally when the ovaries stop or slow their secretion of estrogen, average age 51, 52. Prematurely, it could be because of a hysterectomy if the ovaries were removed, chemotherapy or radiation treatment that impacts ovarian function, or for some people, what's called premature ovarian insufficiency or a loss of ovarian function less than the age of 40 or in that reproductive time frame. And that is a medical condition that needs evaluation and management. Some of the changes occur. Essentially, I tell patients in every system of the body. So vasomotor symptoms related to some of the cardiovascular or vascular changes, sleep disturbances, mood, irritability, so cognitive changes, and body changes. Every organ system has estrogen receptors, so every organ system is impacted by estrogen decline, and we'll unpack that as we go. Some of the symptoms that you may or may not be experiencing, classically, there's a change in menstrual cycle. So menstrual periods, like I explained, start to fluctuate. Vasomotor symptoms would be hot flashes and night sweats. Vulvar vaginal symptoms can lead to irritation or bladder dysfunction, needing to have, for example, bladder urgency or needing to run to the bathroom. Having urinary incontinence could be related to a lack of estrogen or changes in the pelvic floor. And some of the dryness and irritation in the vulvar vaginal tissues can lead to painful sex, or even in some situations, a lack of sensation or a lack of being able to follow that sexual response cycle. So potentially a reduction in sensation or even pleasure, or other means of sexual health concerns. And sleep disturbances, which are again related to the hormone imbalances. People also experience cognitive or psychological challenges sometimes with hormone fluctuation. Not everybody, but there may be memory or concentration or cognitive concerns. The studies have shown that these are measurable, so you're not going crazy. This is actually happening, but transient. In other words, over time, they will get better. So if you're always someone who can't remember where your car keys are, you're probably not going to get better. But if you're someone who that's just happening to around this menopause transition, then it's probably something that will go away over time. We know that depression, anxiety, and moodiness tend to be worse around the time of menopause because the brain, the irritability, it all is essentially impacted by that lack of estrogen. And so again, you're not going crazy. These things are actually happening, but not to everybody. Everyone's menopause is unique. We know that vasomotor symptoms affect up to 80% of women and sometimes very severe. They vary in frequency, duration, and the number of years that you may experience them. They tend to be worse in smokers or vapors or things that could otherwise negatively impact ovarian function. And they impact quality of life, sleep, mood, cognition. Hot flashes, interestingly, may be associated with cardiovascular disease independently. So people who have, for example, worse hot flashes may have worse other medical conditions, and we're not 100% understanding that, but it may be related to blood vessel function and blood vessel health. Osteoporosis can become an issue with all the bone loss associated with menopause, and breast cancer increases with age and is something that women with age have increasing risk of, and we'll unpack the risk of menopausal hormone therapy with breast cancer, but in a nutshell, it's a very, very low risk, if at all, with menopausal hormone therapy. But we always know that women need screening for breast cancer prevention and as well as colon cancer prevention screening. So these are some of the screening modalities that kick in around this age range and need to be discussed with your family physician. So the vast majority of vasomotor symptoms remain untreated. I recently read that about 4% of the North American population uses menopausal hormone therapy. You're going to see some of that data in some of the subsequent slides. But why is this? There's confusion about safety and efficacy and availability of therapies. Women are getting misinformation from all over the place and are unaware that there are both hormonal and non-hormonal options. And our clinicians in Canada and North America are not well trained to manage menopause. And that is very evident in some of the pre-submitted questions. And I'm hoping today clarifies ways that you can advocate for yourself and or continue to seek out a menopause provider.
Dr. Hansen, we have a question about
absolutely.
symptoms. The question is, how can PCOS influence perimenopause/menopause symptoms? Is there any research or resources that explores this?
Wonderful. So PCOS, polycystic ovarian syndrome. And I did a video for the webpage on polycystic ovarian syndrome, which unpacks that a little bit. In terms of PCOS, it is in and of itself a hormone fluctuation. And so with PCOS, the ovaries are not efficient at ovulating, and because they're not efficient at ovulating, there tends to not be that same increase in estrogen and then increase in progesterone, and there tends to be an accumulation of essentially hormones that can be transferred into more male hormones. So PCOS tends to be symptoms such as acne, oily skin, hair growth on the body. We call that hirsutism, and like chin and chest and abdomen, places where people normally don't want their extra black hairs and they'll go have waxing or have it removed, as well as other conditions, which are really important to know about with PCOS, such as heart disease, high blood pressure, diabetes, and over time, PCOS, because of that hormone imbalance, can lead to endometrial precancer or cancer. And I think anybody that has a diagnosis of PCOS needs to be under good care of a gynecologist. Your family doctor may be able to manage, and or an endocrinologist, because of those chronic medical conditions. Now, in terms of the actual studies that tell us, do people with PCOS have better or worse perimenopause or menopause? I haven't read anything that clarifies that, but with respect to those hormone imbalances, we do know that perimenopause is also impacted by similar ovarian hormone imbalances. And so perimenopause can feel a lot like PCOS. And so being able to understand which of those diagnoses you have, what are your hormones doing, and ultimately what we're talking about today, how to balance those hormones or manage those hormone symptoms. So I hope that answers, and if not, we'll take a follow-up question shortly.
Thank you. That's the only question at the moment.
Okay, thank you. I love it. And let's talk about some menopause considerations. So I'm going to hit some of the highlights here before we kind of dive deeper. Some of the highlights include all of the organs that are impacted by estrogen we talked about. Weight gain. So women gain an average of 5 pounds, about 5 pounds a year actually at midlife. And the studies have shown us that that's mostly related to aging, lifestyle, not specifically menopause, and hormone therapy, menopausal hormone therapy does not cause weight gain. But menopause, however, creates significant body composition changes. And so to unpack that a little bit, because our pre-submitted questions did focus quite a bit on weight gain, this is minor weight gain. So over time, it can accumulate 5, 10, 15 pounds. But if it gets into the range of 30, 40, 50, 60 pounds of weight gain, this is not related to hormones, not related necessarily to menopause, but could be related to body composition changes, which may have an underlying impact. So what happens? And we're going to come back to diet and exercise shortly as ways of mitigating some of these changes. But I'm diving a little bit deeper here because of the questions that we received. With body composition changes related to menopause, there's what's called sarcopenia, which is loss of muscle, which can be 3 to 4% muscle loss per year if you don't offset that muscle loss with muscle building. And it also, the hormone changes create an increase in body fat and also fat accumulation in areas where we didn't used to have it. So around the middle, central fat, or we call that central adiposity, adipose tissue. Menopausal hormone therapy can help a little bit with that central menopause, or that sort of widening of the waist. And so menopausal hormone therapy could help with that. But we know that because of the loss of muscle, and we also will talk a little bit about the loss of bone, that muscle resistance training, muscle strengthening training will help both bone and muscle losses that are occurring because of those hormone changes. And when you have more muscle, you burn more, you have better metabolism. Your muscle is your most metabolic organ, so it is going to help you maintain your weight. It's going to help you so that you're not losing weight over time. And in menopause or perimenopause, women also tend to go into what's a little bit, it's not prediabetes or diabetes, but it's a little bit of insulin resistance. So we become, because of that estrogen decline, we become a little bit more resistant to insulin, which means we're not pulling blood sugar out of our blood the way we used to. And in order to mitigate those changes, of course, diet impacts how much blood sugar you have, and we'll talk a little bit about that, but muscle impacts how much blood sugar is left in your blood. And so as you have more muscle on your body, it's going to use more of that glucose or that blood glucose, and it's going to offset that hormone related insulin resistance that tends to start to occur around the time of menopause. So this is complicated. And just to break it down, you want to build more muscle. You want to offset any onset of insulin resistance with diet and exercise. And menopausal hormone therapy may help to stabilize the hormones. It may help to offset that insulin resistance. It has been shown to help offset that central fat that starts to accumulate. And estrogen may also ultimately be in that orchestra, as I like to describe the body as an orchestra, in trying to maintain muscle as well. So, which also hair loss, people start to notice because of the estrogen decline, or those black hairs because of the increased testosterone estrogen ratios. We talked about bone density. Hearing needs to be screened. vision needs to be screened. I just did an article on itchy ears, which women tend to notice because of the skin changes all over the body related to that lack of estrogen. And all of those things can be part of the full body changes associated with menopause. I've talked a lot about bone because it's something, no matter what age you are and listening to this, you need to be thinking about bone protection as a woman. And so in premenopause, you want to get to your peak bone mass. And if you have, for example, children in their teens and 20s and 30s, you want to be helping them to ensure that they're doing all the things to have bone health and peak bone mass. Because in early perimenopause, which is the blue on this graph, and late perimenopause, so that's still perimenopause, there's a significant bone mineral density loss. And then, of course, postmenopause, that continues. And that is something we need to be thinking about with our exercise and diet and nutrition. I want to mention postmenopausal bleeding because it's one of the most important things that needs evaluation. So if you've gone a full year without a menstrual cycle and you have postmenopausal spotting or bleeding of any kind, if you've been that full year, you definitely need to see a doctor because that is the first indication of precancer or cancer in the uterine lining. If you're in your perimenopause and you haven't yet reached that year, well, your bleeding can do a lot of things and that may not be a concern. But if you are concerned, have it evaluated. And if you're on menopausal hormone therapy that has a cycle to it, then you may still have a cycle of bleeding, no matter your age. And that's something that you want to talk to your doctor about, but it could be part of your menopausal hormone therapy regime. Mental health or cognitive or emotional concerns, these all tend to be described by a lot of people in the menopausal timeframe. So feelings of being upset, a loss of control, irritability, fatigue, blue moods, all of those things can be caused by those fluctuating hormone levels. And we know from good studies that menopause or perimenopause, both, can actually exacerbate underlying mental health or psychological health conditions. And we know that people who have a history of premenstrual syndrome, so those PMS or even premenstrual dysphoric disorder, which is a more severe form of PMS, which can lead to incapacitating depression and anxiety. If you have a history of that, then your perimenopause and menopause may be a bit worse. If you have, for example, an underlying ADHD or an underlying even bipolar disorder, perimenopause and menopause can unmask or exacerbate those conditions. So making sure you're in communication with your provider who may be prescribing or having to adjust medication. Stress, sexual dysfunction, physical inactivity can definitely contribute to anxiety and depression. And if you're sore and your hormones are fluctuating, then it makes it a little harder to have your exercise routine steady. And we know that hot flashes or severe physical symptoms can make people a lot more vulnerable to these conditions. And let's face it, this is a time of life when things are stressful and coming to a head in a lot of areas. So aging, unrelated to menopause, aging in and of itself can contribute to some of the conditions and symptoms we're talking about. People who are wanting fertility but starting to reach, their 40s and starting to think about, am I going to be able to continue to ovulate and have a pregnancy? That can be stressful for people. Sleep problems, underlying medical issues, divorce and being widowed in this time frame can be also a significant stressor. Empty nest syndrome, some people transition that really well, others have challenges, and also caring for children, caring for ailing parents. And then, of course, at this time of life, 40s, 50s, 60s, career is becoming paramount. And so those stressors can sometimes contribute to some of the symptoms as well. So those are menopausal considerations. Let's dive into treatment. Treatment is, Mylan.
Yeah, question. You might be answering this question in your treatment section, but someone asked if there is a benefit in using GLP-1 semaglutides at this point to counteract the body composition changes with menopause.
Yeah, that's a great. Go ahead.
I'd just say another question you might want to address is there any advice for a woman with an IUD who doesn't know if she's experiencing perimenopause or menopause or where she might fall within that?
Yeah, great questions. With respect to GLP-1s, the information currently available for those is there for treatment of obesity, and they're also diabetic medications. They are not currently standard of care for menopause body composition changes. So as I discussed, the body composition changes, which can lead to increased fat, can lead to a starting of insulin resistance. They don't reach the diagnostic categories to be using GLP-1s. And so people who are using GLP-1s that is not in those categories of obesity, diabetes, are using them in what's called off-label, and we just don't have the studies to show long-term safety and efficacy of GLP-1s for that condition. Really great for treating obesity, for treating diabetes in certain circumstances, for treating diagnosed diabetes or diagnosed insulin resistance. But right now, it seems like everybody's prescribing them because everybody wants to lose a few pounds, and that is definitely not something that has been studied for safety or efficacy. And I would caution against that. And I would doubly caution against using compounded versions, not the pharmaceutical or brand name versions. And the reason being is we don't really know how safe compounded versions are. And generally, that's what's being offered in some of the more easily accessible GLP-1s. So, good healthcare provider, understanding your diagnosis. There's a lot of obesity specialists who would be able to do this very well, who are not necessarily menopause specialists, but they could manage the obesity and metabolic concerns. So more studies needed in that area, and seek out the care of a medical specialist before starting those treatments. And then as far as an IUD goes, it depends what kind of IUD it is. So if it's a copper IUD, it shouldn't impact hormones at all. And so the hormone fluctuations you're experiencing are likely related to your own ovaries and your own hormonal changes. So yes, perimenopause and menopause can happen then. If the IUD you're using has progesterone in it, so like a Mirena or Kyleena or Skyla, those secrete a little bit of progesterone, and those are going to likely thin the lining. So you won't necessarily notice the uterine changes. In other words, the menstrual irregularity that is associated with perimenopause if you have one of those IUDs in, because it thins the lining medically, and you won't notice those changes. But if you're starting to notice a lack of estrogen changes, like the ones we've been talking about, that even if you have your IUD, you definitely are potentially a candidate for estrogen treatment, because that IUD doesn't have any estrogen in it, and the progesterone is potentially masking those menstrual cycle changes that would indicate you're entering perimenopause or menopause. Happy to take follow-up questions on that as we go as well.
Yeah.
Yeah, so therapies are broken down into, I like to break them down into prescription and non-prescription. And under prescription, there's hormonal and non-hormonal. So let's look at each of these categories. If women are uncertain about what to use, or if there's something available for them to help with their symptoms, or to help them with prevention, they tend to use ineffective therapies or delay using therapy at all. And so that's the goal of what we're doing here, is to create certainty, to create clarity, to help you understand that delaying treatment is not going to be in your best long-term interest. And whether that treatment is hormonal, non-hormonal, or lifestyle related, whatever that treatment or management option is for you, start to think about how you can be informed and use those modalities to optimize your health. Treatment is generally focused on vasomotor symptoms, on sleep disturbances, on mood changes and irritability, and then also estrogen and progesterone will impact bone, heart, vulvar-vaginal area and bladder and brain. So we're going to focus treatment on what are the symptoms. And the other, I actually didn't get this question pre-submitted, but it's a question I hear a lot. What hormone levels do I need to have tested in order to guide treatment? we do not need to test hormone levels. So if anybody's offering you expensive hormone tests or online hormone tests to tell you if you're in perimenopause or menopause, do not pay for those, because no hormone test is going to tell you. It's symptom related. We know that hormones fluctuate so considerably over the day, over the week, over the month, that testing your hormones is just a number on a page. What's most important is we focus on symptoms. And we do get a question a lot of times about, well, I want to go the most natural way possible. Let me just describe natural, bioidentical, and synthetic. So natural is anything that comes from plant, animal, or mineral. Synthetic is anything that's created or modified in a lab. And natural does not necessarily mean more safe. Synthetic does not necessarily mean dangerous or unsafe. And so we need to be very, very clear. Let's give you an example of a natural menopause treatment, Premarin, from pregnant mare urine. So Premarin is an estrogen medicine that has been used as an estrogen in menopausal hormone therapy. It has been studied. It's mostly safe, and I'll share a bit more on that shortly. But it is very natural, and it is not generally thought of today as sort of the first go-to estrogen option, but it's entirely natural. And there are other natural, for example, supplements that are not necessarily safe because they impact your liver or your kidneys. So natural does not necessarily mean safe. Synthetic means it's been created or modified in a lab. Good example in menopause is estradiol. It's a bioidentical plant-based estrogen, and it's been modified in the lab to be put in a patch or a gel or a cream so that you can use it on your body. And bioidentical simply means it binds to the human receptors and gives the impact that we're looking for. So synthetic does not mean dangerous. In fact, estradiol, which is one of our most bioidentical versions of estrogen, has been modified. So I will often describe, we want to go with body identical, bioidentical, estrogen, and progesterone. But some people will say to me, I just want something that is convenient. I don't want to have to take my estrogen and progesterone separately. I want a patch that does it all or a pill that does it all. In that case, we would go to something synthetic, also studied to be safe, but modified to have a greater shelf life, or to have a version that is more convenient for a formulation that is more convenient to be delivered to the human body. So it's really important that you know what you're talking about before you say, I want something natural, I refuse something synthetic, and to really know what bioidentical means. Custom compounded is done, formulated in a compounding pharmacy. So just like I was talking about, some of the obesity medications are compounded. We want to avoid compounding of any kind unless you have a severe allergy, for example, to a pharmaceutical, because compounding pharmacies do not undergo the same rigor of quality that other pharmacies do. Health Canada approved means it's passed that rigorous scientific testing. So those are the modalities that are guideline-based and evidence-based. And pharmaceuticals would be better than, for example, using something compounded or something over-the-counter. Over-the-counter supplements or over-the-counter modalities don't have to undergo the same pharmaceutical approval or Health Canada approval. So I hope that clarifies some questions that we have seen coming in. Let's talk about hormones. Menopausal hormone therapy. Oh, yep.
Hi. Your feed is frozen at the moment, Dr. Hansen. Do you want to try to turn your camera off and back on to see if it refreshes? We also have a question that might be relevant to this next section on what are the vitamins that are essential after 50. Dr. Hansen, I think you are frozen at the moment.
Hello. Can you hear me?
Yes.
Okay. My other screen has frozen, as I heard you say, and then I didn't hear anything after that. So let me just start sharing my slides again. Do you mind if I just pick right up?
Yes.
Okay, just give me a minute to catch up on my slide deck, and I am so sorry for everyone's inconvenience. We'll go right to talking about hormones. Mylen, are you seeing my slide deck?
It's currently loading. Yes. Yeah, we're good.
Okay, thank you, and thanks for letting me know. So yeah, we're going to talk about hormones, menopausal hormone therapy in the form of prescription hormones. And then we'll go through non-hormones and we'll go through non-prescription. In terms of approved indications, menopausal hormone therapy is approved for vasomotor symptoms, hot flashes and night sweats, bone protection, premature surgical menopause, for example, if ovaries have been removed, and genital urinary syndrome of menopause. So that's vaginal menopausal hormone therapy as well, will help with vulvar, vaginal, or bladder issues. And if I could just get acknowledgement that you're still hearing and seeing me.
We can hear you all. We can't see your face though. We can see your slides though.
You can see my slides. Okay, great.
Yes.
I'll turn my camera off. Okay, no problem. So just let me know audibly so that I know that we're still together. Menopausal hormone therapy comes in estrogen and progesterone. So estrogen is the hormone that's going to improve those vasomotor symptoms because estrogen decline is causing them. And then progesterone we use for endometrial protection to protect against precancer or cancer. And we use this term progestogen, you might see, which ultimately includes both synthetic progestins and more natural progesterone. So we use the word progesterone to mean natural progesterone. And what you just need to know about that is that you need to be on some form of progesterone, progestin, progestogen if you're taking estrogen. But if you're only using vaginal estrogen, then you don't necessarily need to protect the uterus because that vaginal estrogen is not as absorbed systematically. Right. And confirm you're still hearing me just to double check.
Yes.
Okay, great. Thank you. And so hormone therapy impacts sleep, symptoms, bones and joints, cognition and mood, diabetes in a positive way. Gallbladder and liver concerns can actually be negatively impacted, and quality of life. So let's talk about those. Sleep. Menopausal hormone therapy is most effective for night sweats, for hot flashes, and also can help with sleep. So if sleep is your main perimenopause or menopause concern, menopausal hormone therapy is very likely going to help reduce your insomnia, help you get to sleep better, stay asleep longer. It is an extremely effective treatment. If you're feeling that you're in this age range and sleep is one of your main concerns, definitely worth talking about starting a menopausal hormone therapy. Bones and joints. We had some pre-submitted questions around joint pain, musculoskeletal concerns, and we know that menopause acts as an anti-inflammatory. And because of its anti-inflammatory effect, when the estrogen decreases, there can be an increase in musculoskeletal pain and discomfort. It's generally not the only symptom, though, but it is one that can be very bothersome if you're not sure what is going on. Hormone therapy can prevent postmenopause bone loss, osteoporosis, and fractures. And the Women's Health Initiative showed a 33% reduction in hip fracture. And we know that after stopping the estrogen and progesterone, there was no rebound. But if you stay on the estrogen and progesterone, as indicated, the bones continue to be protected. The women in the Women's Health Initiative also showed less joint pain and stiffness. Coronary heart disease, in other words, heart attack, can also be impacted by menopausal hormone therapy. So we know, for example, that the Women's Health Initiative did not show an improvement in coronary heart disease, but it really didn't show a significant risk either. So hormone therapy initiated within 10 years of menopause and to women who are less than 60 actually had a reduction in coronary heart disease or heart attack risk. So that's a benefit. And we know that blood clots or venous thromboembolism was really, really low risk, although slightly higher, about less than 1%. But there was, when you look at overall mortality or the risk of dying, it was 30% less for the people who were taking menopausal hormone therapy and likely related to this coronary heart disease benefit. Now, let me be perfectly clear. We don't take menopausal hormone therapy for cardiovascular disease benefit or for prevention. But if you're in this category and you start your menopausal hormone therapy early under the care of your provider, you may see some improvement in that risk. Worth talking about. Hormone therapy represents safe and effective option when initiated younger than 60 in women who are within 10 years of menopause. Now, if you're outside of that group, it doesn't mean menopausal hormone therapy is contraindicated. You may still start under the care of a menopause specialist if you're a good candidate, but this is generally safe. So if you're in this category, it's very safe. Benefits outweigh risks for you to be starting menopausal hormone therapy. Breast cancer is one of the biggest questions we get. There was no increased risk of breast cancer for 7 years on conjugated equine estrogen, which is the Premarin we talked about, so that synthetic version of estrogen. There was no increased risk. And in fact, redoing this data is showing a reduction in breast cancer in that estrogen alone category. When you add in medroxyprogesterone acetate, which is one of those synthetic progestins, the absolute risk was less than 1 in 1,000. So really low risk of breast cancer, potentially associated with the fact that this cohort was average age of 63. And we now know that unless you have had breast cancer, you are or a strong family history with what we call first degree relatives like a mom and a sister, you're actually probably a really good candidate for menopausal hormone therapy, regardless of a distant history of breast cancer in your family. And you should be reassured by this data. So you want to be thinking about for yourself type and dose, duration, whether you do it oral through the skin or vaginal, whether you're in that category of less than 60 or within 10 years of menopause, and you want to think about which progesterone you want to add and ensure that you have that uterine protection. So I'm going to pause for a minute here and just kind of give you, without giving you anybody individualized medical advice, I want to share what I would normally do for a patient in this category is a transdermal estradiol, which comes in a gel. I prefer a patch. I start at a 0.05 milligram per 24-hour patch. It's changed twice a week. So that's the estradiol. That's kind of what I would consider gold standard and guideline aligned, Health Canada approved. And then adding in a progesterone, I like to add in micronized progesterone, which is the natural progesterone, which is taken at night, 100 or 200 milligrams. It protects the uterine lining, and it also has some calming and potential benefits for sleep. So that is the regime. So, and some of the pre-submitted questions to be addressed now, there is no timeline in which you cannot be considered for menopausal hormone therapy. So if you're in the perimenopausal range and you're having symptoms, menopausal hormone therapy can be adjusted for your age and your symptoms. If you're post-menopause already, you haven't missed the boat, it's still okay for you to have this discussion. And depending on your other risk factors and history, you may still be a good candidate for hormonal menopausal hormone therapy. And we want to just talk again about initiating hormone therapy earlier rather than later. So remember I mentioned if people are confused or that misinformation, they may delay using their menopausal hormone therapy, but ultimately the benefits are going to outweigh the risks. And waiting is not necessarily in your best sort of long-term health interest. We've covered all of these things. So the bottom line is starting it in that timing range. Transdermal tends to be a little safer. So that's a cream or a patch. There's no age limit. There's no time when you need to stop. Pre-submitted question, I started my estradiol or my estrogen patch. When do I need to stop? I always tell my patients, you stop when you don't want the benefits anymore. I also jokingly, but honestly say I'll probably die with my estrogen patch on because estrogen continues to provide benefit and there's no timeline in which you need to stop. And if you have a doctor at this stage with the current literature who's telling you, oh, you're reaching an age where you need to stop, that is not true. There is no age when you need to stop. It is symptom related and also health related, knowing your full medical history and ensuring it's safe to continue. Let's talk about prescription non-hormonal options. And can you just confirm that you're still hearing me and seeing my slides?
Yes, that's correct. Good to go.
Great. Thank you. Thank you. So non-hormones. These are less effective than hormone therapy. Randomized control trial data support their efficacy. Randomized control trials, RCTs, those are the gold standards that tell us that studies are actually answering the question we want them to answer. A lot of times when you see on Instagram or TikTok or social media, this works, that works, especially in the category of non-prescription or non-hormonal, the studies are not randomized control trials or they're not robust enough with enough power to actually answer the question. So if you're seeing something that you're kind of questioning, it's really important to know, is that data strong enough to say that that's a beneficial treatment or not? So I just want to put this graph up because we don't need to dive deep into all these areas. But if you look at the first column where it says recommended randomized control trial data, these are the non-hormonal treatments that are guideline based according to the Society of Obstetricians and Gynecologists of Canada and the Menopause Society. So Health Canada approved paroxetine. It's also Paxil, fezolinetant or Vizoa, and elinzatant. These are NK3 antagonists. They're non-hormone and they help with hot flashes and night sweats. Other SSRIs or SNRIs, those are selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors. Essentially, these are antidepressants. Paroxetine, also an antidepressant, but other antidepressants besides paroxetine are off-label, but they work for hot flashes and night sweats. And you can imagine they also work for stabilizing mood. They also work for underlying mental health conditions such as anxiety, depression, ADHD, etc. So you want to be thinking about those as good options for menopause symptoms. Gabapentin, to be honest, is not something that I've in my 25 years of menopausal practice have prescribed for menopausal symptoms because we have other good options, but it is randomized control trial shown to have benefit for vasomotor symptoms. Also, complementary alternative medicines such as cognitive behavioral therapy and hypnosis in certain modalities also have good randomized control trial data. If you go to the next column, recommend with caution, oxybutynin, which is a bladder medication, can be a little bit helpful with limited data. Weight loss, although is great for other health outcomes, not necessarily recommended as the best treatment for vasomotor symptoms and menopausal symptoms. Stellate ganglion block is an intervention, and dietary modification. So increasing plant-based diet, increasing legumes and healthy oils has been shown to help a little bit with vasomotor symptoms and menopause symptoms, as well as the anti-inflammatory effect of some of those dietary changes, but limited data, and do not recommend for menopause, so the third column over, do not recommend because of lack of data. Some of those medications, it's interesting to see in there exercise, yoga, mindfulness, relaxation, acupuncture, chiropractic, and neural oscillations. It's not that we don't recommend those things for other reasons, but not specifically randomized control data for menopausal symptoms. All other supplements are in that category. The Society of Obstetricians and Gynecologists of Canada does mention black cohosh and valerian, but if you look at the data really deeply, it's not really good randomized control trial data. There's just some shown to be a little bit of benefit for black cohosh, a little bit of benefit for valerian for sleep. And soy, for example, it works in some people, not in others, cannabinoids, etc. And then not addressed would be Depo-Provera, so that's Depot MPA, and then also wearables. I mean, they're definitely being studied, but not necessarily proven to be helpful. So Fesolinzant and Elinzatant are great non-hormonal options. Elinzatant is new to Health Canada. I don't think it's being manufactured in Canada yet, although it's approved. But for Vizoa or Fesolinzant, you need regular serial liver monitoring. And then we talked about the other prescription non-hormone modalities. So choice is going to depend on whether you've used something before, whether it worked before, whether you have a coexistent mood or mental health condition, whether you have liver function concerns, whether you want to go in for regular monitoring of liver functions, making sure that you're not receiving other medications that would indicate you can't take some of these non-hormonal prescriptions. If you have sexual health concerns, antidepressants tend to make those worse. And so thinking about that as well. So now we're going to move on to non-prescription therapies. And 50 to 80% of women are using those non-prescription therapies, even though there's limited data or conflicting data. So let's dig into what we do know. We do know that having a healthy diet and the Canada Food Guide is really quite good at that these days. Plant-based or plant slant, Mediterranean, reducing simple carbs and increasing healthy oils, but reducing unhealthy or saturated or trans fats is really important and will help with symptoms and will help with a lot of the body composition and also some of the inflammatory, for example, the muscle joint aches and pains. Some of the brain fog can be related to the inflammatory effect in the brain of having a reduced estrogen. So diet can help a little bit to those things. We had some questions around what training to do, and I mentioned already you want to be doing muscle resistance, so actually building muscle to offset that sarcopenia regularly 2 to 3 times a week. And because of the bone protection, you want to be thinking about plyometrics or jumping pickleball counts. So lots of movement, jumping, really stressing your bones regularly. And then sprint interval training or HIIT interval training, high intensity interval training. These are going to help maintain type 2 fibers, for example, different types of muscle. And that will also help metabolic management. So it's going to help with the insulin resistance. It's going to help with muscle metabolism. It's going to help utilizing fuel if you do a combination of these modalities of workouts. So I tell my patients, work out every day, pick something different, and you want to make sure you put in rest days, especially around perimenopause and menopause, to reduce inflammation. And if you're someone who likes to go for long run, long bike, long swim, do yoga, other things that are more stress relieving, you want to do those sparingly at this time because of the increased cortisol and the increased stress response. And you want to allow a reasonable amount of rest and healing to occur between your exercise workouts. Sleep hygiene is really important. Exercise helps with sleep. Cognitive behavioral therapy specific to insomnia helps. A cool bedroom, a fixed sleep schedule, all very important. Only 2 mind-body therapies have shown positive benefit for vasomotor symptoms and menopause symptoms: cognitive behavioral therapy in certain protocols and clinical hypnosis. So you need to find a person who is trained in these modalities, if you're going to go down that road. I think mindfulness and yoga are so beneficial. The benefits outweigh the risks. They're worth implementing. And there's some literature on those that's not randomized control trials per se. But mind body techniques, we know that when people have greater expectations around menopause, in other words, they assume that they're going to do well through perimenopause and menopause, that mind-body connection tends to have a measurable positive effect. So we have good scientific evidence for those two, cognitive behavioral therapy and hypnosis, some evidence that weight loss because of the reduced weight will help with hot flashes, but weight loss itself may not. Mindfulness, S-equal, so that's soy, isoflavones, work for some people, not for others. And what's really interesting at the bottom of this slide, 20 to 60% show improvement with a placebo. And those women who are anxious have better improvement with a placebo. So people who believe they're getting help and feel supported will do better with their symptoms. And I just want to reiterate something I said earlier. Vasomotor symptoms are not just an inconvenience. We're starting to realize that vasomotor symptoms may actually indicate underlying conditions. So their menopause tends to be a wake-up call for women and their healthcare providers to take hot flashes seriously and not diminish them. And management of those hot flashes is really important, whether that's a hormonal option or a non-hormonal option. And as we start to close, just a reminder that you are not alone. There's thousands of women reaching menopause every day, a testament to, the people who are on this call and all the information that is being sought online. Over 2 million women a year in North America enter menopause, and we have a life expectancy of 82 years, meaning we'll spend a good 30% of our life postmenopausal. Women who feel positive and anticipate that this phase of life will be positive have shown improvement, have shown a more streamlined transition through menopause. So women who note that life is better say that it's better because of their professional role at work, because family life is better, because they have more time to commit to partners and sexual relationships, friendships, going out with the gals, self-fulfillment, and putting yourself first, or at least on the list at this stage, and physical health when you have more time to be thinking about a health routine. A lot of times we put that on the back burner when we're raising children, and now it's time to be thinking about, what does my exercise look like? What does my diet look like? How do I improve? It's a noteworthy phase of life, so it's not just, but it is the end of the reproductive phase, which for some people is a positive thing, not having to worry about that anymore, knowing that kids are independent and grown. Parenting is mostly finished, although it never really finishes. An opportunity to reassess, to create a new story. And I hear this all the time. Women feel like, okay, filters off, time for me to put myself first. This is a really good read that shares a lot about the female brain at this stage of life, when we know that we don't have, for example, children hanging on us, people hanging on us. We don't get that increase in oxytocin that we used to. And with less oxytocin, there's less need to be caring for other people. So it's interesting how that has occurred evolutionarily or through creation, that the brain itself changes in the perimenopause and menopause timeframe in a way that allows us to live life differently. And I think that's a really important message. It's never too late. And I always share with women in community that we don't want to ask what the world needs. Ask what makes you come alive, because what the world needs is people to come alive. You doing you is what the world needs. So there's some resources. The Menopause Society at menopause.org is a really great resource. And then the Canadian Menopause Society, the Society of Obstetricians and Gynecologists of Canada, the Menopause Foundation of Canada. All of these are available in English and French versions. And I'm going to put these QR codes up and leave them up at this point for you to grab some of these resources. These are credible, vetted resources that will help answer some of your ongoing questions about menopause. And in a month, we will be getting back together to do another version of Ask the Doctor. We'll be talking about professional women and menopause at work. And I really look forward to that conversation. And I'm going to pause here and see if there's anything we want to answer at this point.
Thank you, Dr. Hansen. Really great presentation, packed with information. There are quite a few questions, and unfortunately today we won't get the chance to answer more as it is already the end. But know that your question might have been answered in the previous webinar, which is posted on our page, and might be answered as well in the next one. So we will relay these questions to Dr. Hansen for the next webinar that is planned at the end of March, as she was saying. Thank you so much, Dr. Hansen, for your time and sharing your expertise. It's very appreciated.
Thank you so much for this and for sharing this valuable information with your audience. It's been an absolute pleasure to be here, and I look forward to next time.
We do too. Have a good day.